Well, this is a treat. It's great to be here addressing the Department of Surgery. When you have an academic career, you end up developing what we call the canned talks. And it's just interesting taking this job and moving to Mount Sinai, because now this is the first time I've given this talk, which is more of a sort of a broad overview of critical care in general. What I'm going to do today is start by taking a look back and describing to you what I've been able to learn over the last 7 months here about the history of critical care at Mount Sinai. It's actually very rich and very interesting. I'm going to talk a little bit about organizational structures in ICUs and how that's changing these days. I'm going to go over what I view as the basic fundamentals of critical care now in 2014, 7 rules of thumb to make us all great intensivists. And you may be surprised that the overall gist of the message is less is more. I'm going to talk about my personal interest in emergency medicine, because one of the most fun parts in critical care is working on that battlefield whereas humanity, we battle death. And what are the challenges for us to save lives? And really, that's what we do in the ICUs. When the chips are down for these complicated cases, we're trying to save lives, and it's hard. It's not like a sporting event where one guy always wins and one guy always loses. You can lose, 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 lose. And then finally, I'm going to talk about the Institute and some of the organizing themes of the Critical Care Institute. And I'm going to end with a program that we're going to start at Mount Sinai. It's, I think, a very important message for everyone in this room to hear about how we get in trouble when we try to fight what I call the good fight. And through the process of prolonged critical care, we actually actively create devastating outcomes among living, machine-dependent, hospital-dependent human beings. And what are we going to do about that? And how are we helping? And what are the new approaches that we can take to try and prevent some of that human tragedy, which I think is really the only correct word for that term. So this is Dr. Chris Brian Brown. I met him when I first showed up here in February. He's currently an emeritus anesthesia professor at Einstein. And I was interested in looking at the history of critical care at Sinai. I'd done some reading, and he gave a talk. We've instituted a new critical care grand round, so if these rounds aren't enough for you, and you're having a slow academic day, you can come at 3 p.m., which is when intensivists like to round, because everybody's upstairs rounding now at 7 a.m., hopefully, and you can learn more about critical care. So more to come about that. He gave a talk, and these are a number of his slides. So he talked about the history of critical care medicine in general, and one of the first figures is actually a neurosurgeon named Walter Dandy. He's one of the giants in neurosurgery, and he actually gets credit as setting up the first ICU with 24/7 high-intensity nurse-to-patient ratios, and it was a 3-bedded neuro-ICU at Hopkins in 1927. So maybe it isn't so strange that now we come full circle and we have a neurointensivist basically charged with helping to create teams of people to create an innovative Critical Care Institute at Mount Sinai and for our system. When you talk to people, though, well, what's the story about critical care? Clearly, one of the major innovations and developments was the use of positive pressure ventilation and the polio epidemic of the 1950s. When you look at critical care, it tends to be initially focused on young people that have a lot to live for. That's why trauma really is sort of the defining model for the way that we want to approach all emergencies all life-threatening emergencies and critical care, because trauma, as we know, is a young person's disease. You can go in, there's clear surgical objectives, you can get somebody on life support, and then they can go on and live their life. Well, the polio epidemic of the 1950s was a similar heart-wrenching epidemic. As you know, lots of young people got this gastroenteritis. They developed acute febrile flaccid paralysis, and they needed to be maintained on ventilation. And the old model was the negative pressure ventilators, the drinker tanks. They'd put you in a tank physically for weeks to months. Many people would die in the tanks. And you generate negative pressure because that's how we breathe. But it was in Scandinavia where they said, let's try putting a tube in and blow the air in with positive pressure. And it was Bjorn Ibsen, who was called the father of multidisciplinary critical care, for innovating endotracheal intubation. At the same time, he had this whole thing about multidisciplinary care in ICUs. And I'm going to be going back to that because the model that works in the ICU is team-based care and multidisciplinary care, which is a challenge when you've got lots of different doctors and other caregivers coming in with all their strong opinions. Not everyone's opinions always match up. So it's a daily process of building consensus and collaboration and taking the many good ideas and opinions and delivering to that patient a unified and coherent plan that's not at odds with itself. But the giant at Mount Sinai was a guy named Will Shoemaker. I knew of Will Shoemaker, but I was not aware that he actually started his career at Mount Sinai. He is a giant in the field of modern critical care. You see his quote here: "The function of the ICU director is to maintain all the patient systems in equal state of failure and to keep all his medical consultants equally unhappy." Because this was a new model. He came to Mount Sinai in 1970 and established Sinai's first intensive care unit. He was the lead author of the predominant critical care textbook that was initially published by the Society of Critical Care Medicine. The Society of Critical Care Medicine was founded in 1971 by 26 people. Years later, in 2002, I was lucky enough to be a part of a small group of people, 7 people, and we founded the Neurocritical Care Society in 2002. Our first meeting, we had 80 people. And a meeting that I just attended a few weeks ago, we had over 1,000. So field is growing. So according to Chris Bryan-Brown, this is the story. Leslie Rendell Baker was an anesthesiologist, and they had a 4-bed respiratory unit. It was a machine ventilator unit, and they had a hyperbaric oxygen chamber right over on 5th Avenue. Alan Kark was the chairman of surgery. So the origin of critical care at Sinai comes from the Department of Surgery. He had heard about Will Shoemaker and recruited him to come to Mount Sinai to set up a new 16-bed surgical ICU that was called Falk 5. It was in, maybe people, I'm sure some people in the audience know which physical building it actually was in. I think it was just a little bit north of where we are now. And they had a division of surgical metabolism. Will Shoemaker approached Chris Bryan-Brown. He was an anesthesiologist on staff. He had originally trained at Oxford. And he says, Chris, we're going to need some anesthesiology help here in our new ICU. They hit it off. They formed a partnership. They brought in some other people. They had to fight with their chairs to get hospital funding lines to establish the Falk 5 ICU. And they established that unit. There were 2 dedicated research beds. They did tons of physiologic experimentation, or actually physiologic recording of what was happening to these critically ill patients. It was deeply enmeshed and embedded with research. Now you see they had their own stat lab. They were running their own specimens in the unit, and that was the model that I grew up with when I was a medicine intern in 1988. We were running spinning crits and running our own blood gases in the MICU up at Columbia Presbyterian. They opened that unit on April 10th, 1970. And you can see here the staffing that they had. It was kind of a big team, and that was the unit for this hospital. 18 ICU beds. Today we have 83 in this building. So things have developed, things have grown. And interestingly, about 30% of the patient population back in 1971 was neurosurgical. Amazingly, there were 80 myasthenia gravis admissions a year. We hardly ever see myasthenia gravis anymore. It was something that neurology, neurointensivists kind of cut their teeth on. The disease went away because the chronic disease management is so good now. Nobody develops respiratory crisis. You see major surgery, major vascular surgeries, and a variety of other types of disorders. And there was a huge focus of research here at Sinai on the pulmonary artery catheter, or the SWAN. That was kind of the thing back in the day. Developed this way to now monitor intravascular pressures and flow in the heart. And this actually was this was the pillar of what Will Shoemaker was using to study shock. So Will Shoemaker, what he did, if you go through all his old papers, he watched people go into shock and live or die with shock. And then he was able to create these kind of graphs. And you see here an example from one of his old textbooks from the 1970s. And you see this peak hypermetabolic response. The solid lines are the people who live, right? So people become hypermetabolic. There's a lot of cardiovascular demand. And you see here, these are the people who die, and they have failure of the circulatory system. And you see the cardiac index dropping. Right, probably if you could have done an echo, right, you'd see that left ventricular ejection fraction falling down, oxygen delivery falls, oxygen consumption falls, and the patient dies. As I'll tell you that as a neurologist, it's interesting because at the same time that he was at Mount Sinai in the 70s watching the natural history of death from shock, just a couple of blocks down south of us at New York Hospital was Fred Plum. And Fred Plum was the chair of neurology there, and he wrote the book on coma, right? It died stupor and coma. And when you look at what Fred Plum was doing in the early 1970s, he was watching people die of brain herniation. And he was documenting how you have a rostrocaudal progression of loss of neurologic brain and brainstem responses until the patient becomes brain dead. So we've come a long way. We've got tons of intervention, and the pioneers in critical care were really just charting the territory. We still struggle with sepsis on a daily basis, as we just saw in the latest M&M case. And in neurocatastrophes, we still struggle with these devastating cases of brain injury. This is Max Harry Weil. He was the founder of SCCM in 1970, and these are the first 8 presidents. 2 of the first 8 presidents of SCCM were Mount Sinai people. Mount Sinai has a rich history in critical care medicine. And some of you may know Thomas Iberti. This is a picture of him that's in the surgical SICU conference room right now up on GP6. Tom was a high-energy guy. I never had the pleasure of meeting him. I guess when he passed away, unfortunately, tragically, at the age of 40 in 1991. He was already well-established in the field, participating in multi-center trials. He was a dynamo from everything that I've been able to learn from people that know and remember Tom Iberti. He was a dynamo. He actually developed and validated in an animal model in humans are still to this day method for measuring intra-abdominal pressure using a Foley catheter. And he also was one of the first to start very early on, actually around in the late 80s, was starting to question our knowledge and use of the pulmonary artery or SWAN catheter. Starting to raise questions, do we really know what we're doing with these numbers? And this is a JAMA article that he first authored. And now, as we all know, the pulmonary artery catheter is sort of history. And we've got other better cardiac monitoring systems. So I want to tell you a little bit about my story as well, and about neurocritical care. And I have, I call myself, I'm a sort of a general meat and potatoes intensivist. I want to know the sort of the basic good stuff about various aspects of general critical care, and then I'd like to think I'm pretty good at neurocritical care. And I will tell you right now, I'm a big believer in specialty critical care units, which is the US model. It's the Sinai model. The 5 units that we have in this building parallel exactly what we had up at Columbia Presbyterian. And brain and heart get their own specialty units, which I think is okay. But be aware it's a different model around the world. In Canada, in Australia, New Zealand, there's only one flavor of ICU for everyone. But I'm a big believer that having specialty units is what allows you to really focus on very sophisticated, high-intensity, cutting-edge interventions, monitoring systems, et cetera. And we see a lot of that in neurocritical care with advanced brain monitoring. I'll just show you some examples of that. And obviously in cardiothoracic, with all of this advanced circulatory support that I believe we're going to see more and more and more of. And it's going to get better and better and more miniaturized and easier to use. I think we're going to go a long way. Neurocritical care, actually, the modern neurocritical care model did not come from the polio epidemics, because polio went away. They got a vaccine. Those neurologists that were doing trachs and ventilating patients, they went back to the office. And it was really neurosurgery, modern neurosurgery, that led to the current field of neurocritical care. And because these neurosurgical ICUs began to proliferate. And we have a unit now up on Annenberg 8. It's called the Neurosurgical ICU. And there was, interesting, I don't know if you know, but Errol Gordon has a sign, and it says Neurological Neurosurgical ICU. It sits in his office because one of the neurosurgeons came and said, nope, put up a new sign, Neurosurgical and Neurological. He wanted neurosurgery first. Well, really, in my view, it's not about neurology, neurosurgery, and that's why I like the term neurocritical care unit, because it's non-denominational, it's agnostic. It's not about where you come from. The ICU should be an open place for everyone. It's not owned by one specific group or faction or clan. But neurosurgical ICUs did start that way, and there was a neurosurgical ICU up at Columbia Presbyterian. It was only for neurosurgery. And so the sick neurologic patients were floated, scattered around. They might be in the MICU, et cetera. And in the 1980s, my mentor was a neurologist who was also an internist named Matthew Fink. He's now chairman of neurology at Cornell. And he striked up a partnership or a collaboration with neurosurgery, and he said, why don't we start to admit some of these neurological patients in this unit as well and kind of make it a unified unit for neurology and neurosurgery. That led to the whole model of academic neurocritical care. Not surprisingly, most neurointensivists started out as neurologists. That's now changing. And internists are getting into neurocritical care. I've trained emergency medicine folks, anesthesiologists. It's open for everyone, but that was kind of the model, and I thought that that was a cool place to hang out. You'd be interested to know, though, that that initial neuro-ICU was, had the knock of being a single system unit. So when I was a resident around 1989 and 90 in that neurosurgical ICU, if you became septic or had a PE, you had to be transferred to the MICU because the MICU was a real ICU. And ours was sort of a fake or baby or make-believe ICU. And that's completely changed now. So now all units have to be able to handle the standard set of critical illness problems. There's a standard set and there's an advanced set of problems, in my view. And so the model that I developed at Columbia was a kind of fully integrated, single team. When you're admitted there, you're a neurocritical care patient. Doesn't matter if you have myasthenia, if you had a 12-hour brain operation, everyone's in there, and we need everybody's input, and we all hold hands. So ICUs actually, I believe, are the hubs of modern American medical centers. It's where all the action is. You're in the center of the action, And we're receiving our patients from the ORs, obviously, for our surgical ICUs. We take the people when they're crashing on the floor. More than half the patients admitted to the MICU here actually admitted from the floor. They try to take care of them on the floors. They go sour, and the ICU is there to basically try to save them and bail them out. Obviously, I'll talk more about the relationship of the ER and the ICU. And another very important function of a tertiary care medical center is to take patients from other hospitals that can't provide the advanced level of care that we can. And I'm going to admit to you that that can be a challenge because the units are always full. So this is something for the Institute to focus on. I'll talk a little later about ICU access. Because we need, I can tell you one thing, we need a better system. We need better ways to get patients into our units and get them in fast. When I was in about 10th grade, this movie came out, Coma. You may recognize it was a medical thriller, and it was sort of science fiction, and there were scenes of these patients being suspended in some kind of medical science fiction-y place in states of suspended animation, and that actually became reality. And this is the modern neuro-ICU of today. This is a patient in a coma with a severe brain injury. She's got 5 different types of brain multimodality monitors in her brain. She's on therapeutic hypothermia. She's on multiple pumps and infusions. And this patient gets better and recovers and one day walks and talks. So for me, the biggest thrill of my job is watching people that I used to see die over and over, and then being part of something where now I see people that used to die who now live. That's the thrill of being an intensivist. And I think that the most challenging and exciting area for us, in addition to minding all our P's and Q's on taking care of the people that are kind of sick and pretty sick, are really fighting that battle on the front line of life and death and taking care and trying to save the sickest of the sick. When I heard the last presentation in M&M, all I could think of in my mind was, what the hell could we have done to have saved that guy's life? And these are the challenges. So this is a slide that I developed about neurocritical care, but I really think that it applies to intensive care units in general. ICUs are the nerve center. They're the hub. And the whole thing, open, semi-closed, closed units, the important thing is that what it allows us to do is standardize care. Now, one thing about me, I come from the early 1980s era of punk rock. That's the music that I like and I'll listen to and relax. It may not look like it. And I never was much of somebody that was into regimentation and standardization. So I don't believe in standardization for standardization's sake alone. I'm keenly interested in finding out what really can make a difference, what really works in standardizing that stuff. That's what I think, and that's what, by unifying the way that we work in units, that's the power, that's what it allows us to do, is doing it the best way that we can every time for every patient. So the problem with the open model is, right, every individual doctor admits in their own name, and they're master and commander of their patient. They've got their belief systems, their idiosyncrasies, and you get this chaotic picture where it's all being done differently, and the nursing staff has to find out, well, how does Dr. X want this thing done or why? Right? By unifying, moving towards a semi-closed or closed system, everyone gets in the room, you have one big powwow, and you have a conversation, say, well, let's just all decide to do it one way. It may be the best, it may not be the best way, but at least it's one way that's consistent. And what's powerful about that is that at least if you decide as a group or a team to tackle a certain problem one way, if you keep track of how you're doing, then you get to find out how that way works or doesn't work. But if it's all being done differently with different approaches or medications or interventions, you can't learn anything. And so much, I realize now, of my research now is going to focus on continuous quality improvement. And my eyes have been open to this model. And we saw some of that, right? We saw the presentation about the surgical site infections. This is becoming a dominant model, experimental model in critical care. We have a problem, we can measure it, we hate it, we're going to team up, we're going to come up with a comprehensive way to try and attack that problem, and we're going to continue to measure outcomes and make that unwanted bad outcome go down. That's a predominant model, and that's something that we're going to need, and I'm going to ask people in the Department of Surgery to work with us in the units to take on these issues and problems using that model to do great things for our patients. The ICU is the ultimate sandbox, and it really is dependent on very, very much on relationships, culture, and philosophy. And there's no real way to BS that. It comes down, so much of it, I'm convinced, comes down to the interpersonal relationships. When you get lots of people working together in a somewhat chaotic environment, right, you can have smooth or you can have friction. But to be a team and get things done, get serious things done that change the way that other people start to want to practice medicine, that to me is the goal. What I want to be able to do is to start to produce research and publications out of Mount Sinai, so people are saying, well, at Sinai they're doing this, and at Sinai they're doing that, and maybe we should do it like Sinai. And I know that we can do this, and just so you know where I'm coming from, I think that that's the fun, and I think that that's the challenge, and I think that that's the excitement. But no individual, I can't do it alone. No one can do it alone. It really is about having a great team and sitting down with the team and getting the team working on a project. There's lots of technology in ICUs. Certainly in neurocritical care, there's been a lot. And that technology has helped to define the field. This was the set of technologies or interventions that were unique to a neuro-ICU when I got my job in 1994. So we were the unit that did intracranial pressure monitoring, that had ventric drains, artificially raising blood pressure to promote cerebral blood flow in subarachnoid hemorrhage cases. We had a Doppler method to measure blood flow velocity to the brain. We put people in barbs. Now in this day and age, this is the current skill set of technologies unique to neurocritical care, and it's spreading out to the other units. It goes on and on and on. Continuous EEG monitoring, therapeutic hypothermia for cardiac arrest and ICP control, all different types of advanced imaging, brain multimodality monitoring. And down here on the right is another thing of great interest to me, which is big data, basically, or multimodality data acquisition. Every day, in these 83 ICU beds, there are reams and reams and reams of continuously recorded physiologic data. And I believe that that data is very rich and can tell us a lot. And the current problem, just so you know what I'm working on, is it's all stored. It can all be stored. You know, look at what server space is these days in the age of Google and Facebook. And all that physiologic data is on purpose flushed and eliminated forever after it's been stored for 2 months, for no good reason that I can tell. So if we can start to archive that physiologic data, maybe we'll be able to start to develop smart early warning systems, so-called data sniffers that can measure the hidden information in our biorhythms that are being recorded at the bedside, like heart rate variability, which has been shown in neonatal sepsis to provide a useful way of alerting clinicians that when you admit the neonates, it's always sepsis, right? They have immature systems, they're immature immune systems, and they die of sepsis. And it's been shown in neonates that this can work. And there's been challenges in developing this in adults. But these are the types of things that are of great interest to me. Neurocritical care, there's a whole body of knowledge or work looking at healthcare outcomes, whether or not people with severe brain injuries are treated in neuro-ICUs or in general med-surg ICUs. And I can understand why, because the young neurointensivist gets their job, and the general intensive care community there is like, well, who said you're any good? It was fine the old way before you show up. And so huge numbers of neurointensivists started doing research to try to validate their own existence. And there's been many of them. And it's just one example of improved survival. And this has been shown over and over. If it is true, if you have a severe brain hemorrhage, you're on a ventilator, if you have a stroke, people do better in the specialty units, in stroke units. And it would stand to reason with the other specialty units too. And it's interesting because then the question will be, well, why is that? Is it some specific therapy? I mean, the stroke doesn't really have a treatment except for TPA, which only 5% of people get, right? There's no approved FDA treatment for intracerebral hemorrhage, right? So why do people do better? And I'm convinced the reason why is that you've got a team of people taking care of the patient that actually believes that they can make a difference. They actually believe in what they can do, and they believe that they have something to offer. And you might say, well, I mean, what's so big about that? But what's interesting about that is I'm talking about having something to offer for people that are really, really sick. Because it turns out in neurocritical care, there was a huge issue with therapeutic nihilism. So, right, when I grew up, right, neurology was diagnose and adios. That's what it was, right? I went into neurology. Everyone said to me, you're out of your mind, Mayor. Why the heck would you want to go to neurology? Do neurosurgery. Do something useful, right? Because you can't, there's nothing to offer. I kind of saw it differently. I saw that there probably were interventions and opportunities to offer, and I wanted to be part of that. And I decided after my residency to go into neurocritical care. And to a certain amount of derision from people in the Department of Neurology as well. I mean, why do you want to do this? And one guy said to me one day, what is this going to be, Stephan's vegetable garden? Right? And there was a lot of therapeutic nihilism, right? And that led to me sort of thinking about, well, what am I here for? And this is a really important message. I decided that if you were going to go in my unit and that you were going to use up that bed day and we're going to park you in there and ventilate you anyway, that we were going to go all out, pedal to the metal, and do absolutely everything in our power. And if we felt powerless, we were going to innovate and we're going to come up with different kind of stuff to try. That basically is the approach. And that's an approach that I hold to dearly and I think is crucial. And I'm going to tell you why. Because coming to Mount Sinai and looking at what happens in some of the units sometimes, people start to do poorly. And the families are asking us to fight for mom, fight for their wife, fight for their husband, fight for their child. And that's what they're asking for. And sometimes we'll sit there and say, oh, it's kind of not looking so good. And we talk to them a lot about, we can talk to them about the expected outcome. But I've noticed a dynamic, and I'm being completely frank and honest, where the teams start to let up on the gas pedal. They start to let up a little bit, right? And I've seen specific examples where the families are furious. They're furious. And they're like, you've already given up. And every time you talk to me, all you want to talk about is stopping and withdrawing and this and that. and it leads to these refractory things. And then what you hear from the team is, family's completely unrealistic. And then it gets dragged out, and then this family they're out of their minds, they won't stop, they won't withdraw, and the family's like, you've already kind of have to withdraw anyway. And it leads to this terrible dynamic of this prolonged stay in an ICU. I really believe that if the family wants us to go full out, full court, then that's what I'm going to do. And I believe that when I have that discussion one day about flipping the goal of care to comfort, if they authentically believe, because they're in the room, they're in the waiting room, they're there, they know, if they authentically believe that we have busted our butt and done everything more 110%, it's easier for them to withdraw life support. It's easier for them to accept and go through those Kubler-Ross steps and come to peace with a decision to let someone go and have their peace and their dignity. But there is a trap with these intractable cases of conflict that I have seen. I'm going to present a patient to you. This was a 34-year-old man who had a cardiac arrest, and I am really going to have to pick up the pace. And he was a young physician, and he was born with a congenital anomaly of his aorta. And it had been repaired once with a graft, and he needed a reoperation. And so he underwent an aortic repair that went horribly wrong, and he had a prolonged cardiac arrest in the operating room. And he ended up in an ICU. He was in a coma with highly refractory status epilepticus of his brain, and he was being treated with pentobarbital in a medically induced coma. And after about 14 days, the family was getting very consistent messages from Neurology that there was absolutely no prognosis, there was no hope, and they were getting strong messages to withdraw life support. And that patient was here at Mount Sinai. And the family went to me. It was the mom and the wife. And they said, we want to transfer him to Columbia. And I figured, okay, well, look, you know, they're in distress, and they just need that kind of second opinion, you know, to sort of validate the reality, because this looks horrific. And, you know, I'm going to do something, you know, do the right thing for these folks, and just give them a second independent opinion on the bad news. That was my idea. So he comes, and if this looks like a gray-haired neurologist, it is. It's J.P. Moore. He was my colleague, still working up at Columbia. I transferred this guy in, and he was running the professor rounds in neuro-ICU, and he's publicly going, what is this? What the heck is this? What are you transferring in? You're transferring in a dead guy, you know, in public and everything. And I'm just like, well, I'm doing what I'm going to do. And anyway, so we stopped the penobarb, and the seizures had stopped. And for a long time, he was GCS3, which means he had like almost no neurofunction at all. He actually had no brainstem function from the penobarbital. His pupils started to react. He was completely quadriplegic. If you drilled his fingernails with pain, you got no response at all. His EEG after the barbs were off was very, very flat. I kept saying I wanted to get an MRI to see how much brain damage there was. And they would not let me. The mom and the wife would not let me because they say, we know what you're going to do. That MRI is going to show damage. You're going to use that as some kind of evidence to support and justify withdrawing. And we don't care. We don't want to know. We're not giving up. We're not giving up. And eventually, I did get the MRI, and you see extensive cortical infarction here on both sides of his brain. And, you know, he was working with the family, and then actually after a few weeks, he started to open his eyes, and he actually started to mouth some words. And eventually, at one point, he could actually wiggle his fingers to command. He got a trach and peg, and we shipped him off to a nursing home. Or to a skilled nursing facility or a rehab or something like that. And they were like, well, now what's going to happen? I said, you know what? He's got a lot of severe permanent brain damage, but he's young. Maybe he'll get better to some extent. He's got to regain his strength from his critical illness myopathy. Maybe one day you'll get him back home in a wheelchair. And I truly, sincerely hope that that's what happens to your husband and your son. I think that he can go on and rebuild his life around his disability. So let's hope for that. But let me just make one thing clear to you. One thing clear. I said he'll get some recovery, but I can guarantee you he will never work again. And here he is. He's a practicing rehabilitation physician at NYU. He's been doing it for years. And I was totally wrong. He has an interesting syndrome where his hands are claws from what we call man-in-the-barrel syndrome, which is something that before him I had only seen in coma patients where you have more ischemic injury in that border zone between the ACA and MTA. And he gets the arms and hands in the motor strip. And so what that experience taught me, and many others, was that I was not as smart as I thought I was. And I didn't know that much about neurologic prognosis. And then I kind of thought about, well, how often had I also gone and told families and strongly said, listen, it's hopeless. There's no chance of neurologic recovery, and basically talked people into withdrawing life support. And I know that I withdrew lots of life support on people with this mysterious syndrome of seizures going into a coma, and they weren't waking up. And now I know, looking back, many of these people were in non-convulsive status epilepticus. But we didn't have the technology then. So I guess my point is that's neuro, and the neuro hits are kind of clean and simple in a way. Multisystem organ failure is really complicated. But I actually believe that there are better ways that we can approach multisystem organ failure. And I'm going to talk about that at the end with this respiratory failure pathway. As time went on, I developed a simple methodology for talking with families, and I want to share it with you. Because when I was growing up, I saw a very disturbing pattern, which was somebody would get horrifically sick in the unit on a ventilator. And literally what we would do is, this is what passed for normal, was they'd go upstairs on the vent with a trach, and we would basically wait for them to die of untreated or half-treated infections and other types of complications. So this kind of watching people slowly die in a respirator, and I just couldn't deal with it. And I developed what I called the 3 paths at the goals of care conversation. So someone's in a really bad state. They can be encephalopathic. They can be sick. But we're talking trach peg. And basically, I would only give the family one of the 3 paths. You must pick a path. If you don't want to take one of the paths yet, that's okay. We will talk more until you are ready to take one of the paths. But you must take one of the paths. You can't say, I don't want to withdraw, but I also don't want to do a trach, and, et cetera. So path 1, trach, peg, full medical support, full optimization, and discharge from the hospital as soon as possible. Right? That's our model. That's the full court press. That's model 1. Model 2, same exact thing, except we start to set limits, and the fundamental place to start to set limits in the ICU is with a DNR, which is an insurance policy. But these DNRs are hardly ever invoked because we're so good. People don't usually arrest, or not that much. And what we'd say is it's a starting point so that even if we try our hardest, if it all collapses and the patient arrests, then we're done. And then the 3rd path, right now, today, or when you're ready, we're going to go to what we now call comfort care, and we're going to terminally extubate you, we're going to put you on morphine, and we're going to flip that goal. And another thing that I still see sometimes, as I've been here for a while, and I saw it at Columbia too, was there's a conversation, and you get the family to agree to comfort, right? And then this happened to me last week in RCU. My fellow did it. It's okay, he's learning. And I'm like, well, then why is she still intubated? family agrees to comfort, and the plan is to extubate. So why are you waiting? And he's like, I don't know why. It's like, well, why don't we just go talk to them today and take the breathing tube out? He's like, oh, okay. And there's sometimes a feeling like, well, they wouldn't be ready for it, or maybe I'm not ready for it, or let's not go too fast. But I actually believe, and it is true, sometimes when families flip that switch and want to go for the comfort, you will see sometimes a tremendous sense of urgency. Let's do this, and let's do this now. Let's not drag this out. And, you know, again, the thing is, around all this life and death and with putting people on life support and withdrawing, you hear again and again, the families are totally unrealistic. And my response to that is, we set the expectations. We need to set the expectations for them. Because if you're a family member, hopefully this is the first time and hopefully the only time in your life where you've struggled with a loved one in a hospital on life support, right? They don't know how to do it. They don't, you know, they kind of come in. We got to educate them and say, if you want life, this is the way we roll, right? That's how we roll. And I'm going to end with the respiratory failure pathway. And if you want comfort, we're just going to do it. We're not going to drag it out or do terminal weans or things like that. So again, I'm going to just move through these slides quickly. Again, we need to be careful, though. Clearly, there are cases where there really is no hope. We know. And then there are cases where there's a lot of hope. And that gray areas is where that's what we do. Recognizing where the grays are, maybe not being quite as confident, having quite as much hubris. And actually, we want to get better and take most people in the gray area and move them into the good outcomes. And that's the technical challenge of what we do in academic critical care medicine. And this is just one slide I'm just going to show you. This was an important paper about the self-fulfilling prophecies with these severe brain injuries. So this was a grand rounds presentation at University of Washington. And the Kira Becker's the young neurointensivist, and she gets up, she presents 3 cases, shows their scans. So suffice to say, this is a devastating brain hemorrhage. 60 is considered classic lethal volume. GCS 6, you know, 2 centimeters of shift. How many would how many of you guys in the audience would withdraw? And 30% would say they would withdraw. This is not a theoretical lady. This is a real lady. And at 6 weeks, she was walking independently. And, you know, the same thing here with these other cases. So just in our literature about just being careful about prognosis. And, of course, the thing to remember about moving forward, making progress in prognosis, I can tell you that in neuro, right, we're always looking through the rear view window, right? We're always saying, right, we're always looking back on, well, previously nobody ever got better with this illness. And I think we need to be a little more cognizant of looking forward. One of the things that I'm interested in doing, actually, is using patient-powered outcomes that can be collected very simply. When we have the family meetings, we're still kind of guesstimating. And I'm like, why are we guessing? You know, why can't we just find out, you know, if we punch in a few prognostic variables for Granny, you know, and be able to show a family, this is a mock-up of what a coma prognosis outcomes calculator might look like. And it was part of a PCORI grant that I put together with a group of other people. We didn't get funded yet, but we're still trying. And it was, you know, imagine just say, well, look, this, okay, we can do the trach and peg and do full support, but, you know, when you're very elder, you know, with this kind of set, this is what you're looking at. You know, you're looking at, based on people, you know, where we have the outcomes here, right? You're looking at maybe only a 20% chance of mild or moderate disability. You're looking at a 50% mortality. I think that this is really important because we do know that the outcomes with chronic critical illness among the very elderly that go to the nursing homes are really horrible. There's a statistic that if you're over 75 and you're trached and you go to a nursing home, right? So this is not up to the minute, up to date, but in centers that have sort of looked over a period of 2 years, you know, maybe 5 years ago, 75% of those people are dead in a year after an average of 5 hospital readmissions, or some statistic like that. You know the drill. And I think it's, you know, would be helpful for us to be able to communicate more real data instead of having us kind of estimate and guesstimate. Okay, I'm going to bomb through a little bit more here to get you guys on your way. Emergency critical care is of great interest to me as well. And I'm just going to say that I think that we have real challenges in our emergency departments, in our emergency rooms. It's really tough to deliver high quality critical care in ERs. And it's something that we struggled with at Columbia and that we continue to kind of struggle with at Mount Sinai. So I'm a huge enthusiast of what I call emergency critical care. It's something that I want to really develop here. I think emergency medicine physicians make great intensivists. We've got that 5-bedded resus bay there. It's still probably not enough for our needs. And we need to, we don't want situations where people are, you know, waiting for several hours down in the ED to get up to a higher level of critical care. We need to be able to deliver a high level of critical care to them when they need it right away. Because at least with the neuro model, time equals brain. And it's those first few hours of critical care in the ER that are actually the most important hours. And this is especially true of sepsis and early resuscitation for sepsis. Cardiac arrest is a big interest of mine, and I'm hoping to develop more innovation and research in cardiac arrest with the hypothermia story that we've got now. If you're up on the data, you know that now the latest research shows that you can cool to 33 or 36 and still get a good outcome. And this is graphically showing, though, that in the original HACA study that put hypothermia on the map, maybe what we're doing now to 36 is just treating some fever. But that's fine. The nice thing is that hypothermia made cardiac arrest a treatable disease, and it gives us more to do, and it creates an opening for us, an opportunity. I was interested to see that 50% of people that get to ROSC in the field still die in the ER in New York City. So there's an opportunity. What can we be doing for those folks? And we need to mobilize sophisticated critical care in the ED for those people. One of the concepts that I'm really fascinated with that I think, you know, may sound like total pie in the sky is something called ED ECMO. And ECMO is something that we had a lot of experience with at Columbia. And the idea is if you've got a reversible cause of cardiac arrest and you can't get to ROSC, you can just slam a large arterial and venous catheter into the femoral artery and vein, turn on the machine, and start to pump and oxygenate the patient. Now you've got tissue viability, and then you can go and try to fix the primary cause of the arrest. This is sort of on the real cutting edge of resuscitation medicine. Scott Weingard, who was EM crit guy here at Sinai, went back down to shock trauma in Maryland to learn how to do ECMO. He's now out at Stony Brook and he's going to try to get a program like that going. It may take a while, but I think it's absolutely fascinating and something that I'm interested in doing. Along those same lines, in stroke, we do these I'm going to stop in a minute, I promise. We do these thrombectomies now where we pull the clot out of the middle cerebral artery. And I learned a little more about endovascular approaches for pulmonary embolism. And I'm like, this is great, right? We can just basically do a right-sided catheterization and just go right in. And you see here saddle embolism with poor vascularization of the pulmonary arterial tree and just pull those suckers out. with some kind of a corkscrew or a suction device or something. This is happening. This is coming. In fact, one of our Grand Round speakers in November is going to be talking about this type of acute PE intervention for pulmonary embolism. But the model's different. Most of this endovascular approach now is for submassive PEs, for people that still have a blood pressure. Now we're talking about doing this in people that don't have a blood pressure. They're actually in the middle of the code. This is, I think, really exciting stuff and stuff that I'm interested in developing. I am so running out of time that I'm just going to end with one last minute or something. I guess I was overly optimistic about how much I could cover. The fundamentals of the ICU, what can I stop doing to this patient? Every day, I believe that's what you should be asking yourself. Turn the sedation off every day, put the patient, turn off the ventilator effectively, put them on a spontaneous breathing trial, get the lines out, get the Foleys out, be as sparing as possible with the antibiotics. Don't give blood unless the hemoglobin's 7, unless they're in some kind of active bleeding situation. And maybe most importantly, get the patient out of bed, which is early mobilization. And then get the patient out of the ICU and out of the hospital as soon as possible, because the hospital is a dangerous place for very sick people. This is the ABCDE bundle, and this is what we're going to be institutionalizing with our respiratory failure bundle. And I'm just going to go through all the rest of these slides. Maybe I can come back someday and give more, because I was overly optimistic. I just want to end with 1 minute on this respiratory failure bundle. So what we're going to be talking about is a better approach for chronic critical illness. Mount Sinai spends $100 million in the system every year to treat 600 patients to get trachs. Their average length of stay is 48 days. At the end of those 48 days, a quarter of them are dead anyway. And of the survivors, 15% are back in the hospital. What happens is when you're going down that path of multi-system failure and chronic critical illness, is the patients are literally wasting away. They're developing this accelerated critical illness neuromyopathy. They become encephalopathic, and they're over-sedated. And there's this vicious cycle of over-sedation, weakness, and delirium. And what we're going to do with the pathways, we're going to try to sort of protocolize the good stuff that we know we should be doing, and in a way, with quality rounding in the units in the afternoons, provide just-in-time peer review. Let's turn the sedation off, have an early family meeting, set the expectations. If you want life in a fight, great, but mom's going to leave as soon as possible with a trach before they're liberated from the ventilator. Do early, timely trachs and pegs to optimize nutrition. When the trachs are done, you don't sedate the patient as much. When you turn off the sedation, then you can have your rehab teams up and getting people out of bed. This is a guy who was ambulating the CTICU last week. He was bedbound. He had been bedbound for 118 days with an artificial heart in the CTICU. This was the first time in almost 4 months that he was up on his feet. And you can see it took a team of physical therapists to get him up. He walked for half an hour, and he loved it. And this is the type of thing that we're working on now, is getting resources. So the answer is, there is good news. The hospital is going to make an investment in critical care, physical therapy. We're going to develop a program around this. And it's going to give us a real reason to turn the sedation off and get these patients more liberated. And the idea is that with this kind of a pathway, we'll be able to discharge stronger and healthier people. They'll be easier to place. They'll have fewer accumulated infections over time, hopefully a lower mortality. And we even want to create a medical home or a call center for this high-risk, high-intensity, high-resource population, so that after discharge, we can stay connected with them and help them on the road to recovery. Thank you very much. Sorry about going over.